Hey everyone, this is JJ Huff, one of the EMS fellows. We're just going to do a quick presentation talking about STEMI mimics. We've had a little bit of feedback from our cardiology colleagues that we are activating STEMIs from the field, sometimes inappropriately. So I want to do a little bit of education on STEMI mimics, things that look like a STEMI, but we should not activate as a STEMI from the field. So some key takeaways for this presentation that we're going to talk about today. In general, we'd rather overcall STEMIs than miss them. Obviously, there's high mortality associated with having a heart attack, and we don't want to miss them. But context matters, right? We'll get into this a little bit later on, but knowing who the patient is, what they're presenting with, what their chief complaint is, what they look like, is going to be very, very important for this. Another key theme is that bundle branch blocks certainly make everything much more complicated, so we'll try and break that down a little bit and hopefully make that a little more easy to understand when reading an EKG. And the last key takeaway that we want to kind of harp on here is that it's our job to call STEMIs in the field. Just because the machine may say STEMI on it does not mean that the patient is having a STEMI, and the converse of that is also true, right? Just because the machine does not say STEMI on it doesn't mean the patient might not be actually having a true STEMI. So use your judgment, use your training to determine whether a STEMI exists or not what the machine says. So to start off, let's take a look at a recent EKG from one of our crews. So we can play the game STEMI or not STEMI. So take a second to take a look at this and see what you think. Just to highlight some things, just looking at this right off the bat, we notice some concerning findings here, right? Looking at lead 2, we see a little bit of elevation in the ST segment there. Same in 3, same in AVF, right? We have some maybe reciprocal depression here in V2. This is a concerning looking EKG, right? This looks like an inferior STEMI, and in fact, this is a STEMI, right? Trust your gut. If it looks like a STEMI and the context is right, it's probably a STEMI. So this was called from the field, and this person did in fact have a STEMI. So that was a good call. Here's another example. STEMI or not a STEMI. Take a second, take a look, and see what you think. So again, just eyeballing this, looking at obvious things that look kind of funky. There's definitely some ST elevation in V1 as well as V2. We have reciprocal changes over here in lead 2 and lead 3, as well as AVF, as well as some elevation in AVL. Right, so this is a concerning EKG. If this patient has chest pain and has the right context, we should 100% be activating this in the field, which we did in this case, and this patient had 100% LAD occlusion. So this was a good call from the field. So once again, this is a STEMI. So what is a STEMI? How do we define this? Well, first of all, it obviously stands for an ST elevation myocardial infarction, right? So how do we define that, right? Someone is infarcting their myocardium from an embolic, usually occlusion of one of their coronary arteries, and that's going to show up on an EKG. Well, how do we define that as showing up on an EKG? What it looks like is new ST elevation, the key word there being new, right? ST elevation of 1 millimeter or greater in 2 contiguous leads, contiguous meaning next to each other on the EKG. There's an exception here though. So V2 and V3, we have a little more strict criteria to call something a STEMI. So it needs to be 1.5 millimeters of elevation in women and 2 millimeters in men. So this is what our cardiology colleagues define as a STEMI, which sounds very straightforward, but as you know, this is very, very complicated. So let's look at a couple more. STEMI or not a STEMI. So just looking at this, take a second, see what you think. For me, just eyeballing this, right? It looks a little interesting. There's maybe a little bit of elevation here in 2 and V3. I could also convince myself in AVF there's some elevation. V2, right? That looks a little bit elevated. V3, maybe a little bit. And then maybe out laterally as well. There's some depression in AVR potentially. This is a kind of a funky looking EKG that might make me concerned, but I need to know who this patient is, right? Could this be an 25-year-old woman who's saying whenever she lies down, her chest hurts and she's had a low-grade fever for a week or so, and when she sits forward, she feels better? That sounds like pericarditis, which this could look like. Is this a 75-year-old man who's had multiple episodes of coronary artery events in the past, or he's had prior STEMIs and had prior caths, and he's having ripping chest pain and his EKG looks like this? I might be a little bit concerned. If it's an 18-year-old who is calling 911 for shoulder pain, I'm probably less concerned about it. So the key takeaway here is that context matters, right? Our typical patients with a STEMI are going to have chest pain or pressure, or they're going to be short of breath, or all the above, right? They should usually have a symptom with this. One thing to keep in mind is that as patients get older, especially women, they may present a little bit differently. So typically older women may just have nausea or something like that that makes us a little bit concerned, and we should still be getting a 12 lead in those patients. But in general, typically you will see chest pain or pressure or shortness of breath. Those are the most common symptoms we see with patients that are having a myocardial infarction. They should also have risk factors, right? These things don't just happen out of the blue. Smoking is a huge risk factor, family history is a huge risk factor, diabetes, hyperlipidemia, and then prior coronary artery disease. Another key takeaway as far as context is concerned is that STEMI is rare in young patients. 90% or greater of STEMIs are in patients that are greater than 45 years old. Now, it doesn't mean that people in their 30s, people in their young 40s can't have events, but we should really, really think hard about it in someone who is younger than 45, whether they're truly having a STEMI or not. Obviously, if they have risk factors and they have these symptoms, we need to think about it, but we should be thinking twice about activating in an 18-year-old with chest pain who might have a funky looking EKG. So let's look at some further things as far as context and why this is important. So benign early repolarization is a very common STEMI mimic that we often see either in the emergency department or in the field that can look like a STEMI but is not qualify as a STEMI. So this is typically seen in young, healthy patients, so they'll be less than 50. We'll see widespread, what we call concave ST elevation. So what does that mean? Concave meaning that this is kind of curving up like this, right? It isn't that tombstone that we typically associate with that ST elevation. This is more concave, so going up like this. And this can look similar to pericarditis, right? Diffuse ST elevation can look like pericarditis, and that can be a little bit confusing. So an example that we can look at. So looking at this EKG, right? Is this a STEMI? Is this not a STEMI? If I'm just eyeballing this thing, right? I'm like, oh shoot, there's some elevation in V2. There's some elevation in V3, definitely significant. See maybe a little bit out in the laterals as well. Maybe a little bit in AVF. This is a concerning EKG, but context matters, right? This patient is 20 years old. The likelihood of them having a true STEMI, right, which is probably going to be an LAD occlusion, looking at elevation in V2, V3, would be so rare. Context matters. This is not going to be a STEMI. This is benign early repolarization. And we know that because this is a little more concave, right? You have this J point notching here, which is pretty pathognomonic for benign early repol. And then the most important thing, context. This patient is 20 years old, right? This is very, very likely not going to be a STEMI. So again, some more EKGs for you guys to think about as we go forward. STEMI or not a STEMI? Take a second, take a look, and see what you think. So just eyeballing it, right? What jumps out to me immediately is these huge complexes in the anterior leads. And I can convince myself, rightfully so, that there's ST elevation here, right? This ST segment is certainly elevated both above the TP segment, right, and my PR segment here. I see that in V1, V2, V3, and V4, and I'm concerned, right? But hopefully we should recognize this as a widened QRS complex with this morphology as a left bundle branch block. This is a very common thing we see. It also resembles a paced rhythm, can look like this as well. When we see a widened QRS looking like this, and then we'll also see sometimes in V5, V6, these funky looking QRS complexes, which can look like either W's or M's. That is a left bundle branch block. And we'll get into how we should not identify this as a STEMI in a little bit. But I also want to show another example of an EKG that we'll commonly see. So same thing here, right? This EKG doesn't look normal to me, right? Just looking at V1, I had this huge elevated segment here that I could maybe convince myself, right, would be ST elevation. Same in AVR, this big segment here that looks like that tombstone. That could be an ST elevation that would make me concerned. But this is a right bundle branch block. So similar to a left bundle branch block, but obviously different, right? So in this case, with a right bundle branch block, we're looking at that M shape usually in V1, V2, sometimes V3, right? And a widened QRS complex. So this is all a QRS complex here, and it's widened. It's usually greater than 100 milliseconds. So this is a right bundle branch block, which you have to use different criteria to identify a STEMI in. So things to keep in mind when we're looking at left bundles and right bundles. So let's get into the nitty gritty a little bit here. Looking at bundle branch blocks and Sgarbossa criteria, which I'm sure you've heard about. So we're going to use Sgarbossa criteria for left bundle branch blocks and paced rhythms when we're trying to look for STEMI. So patients with chest pain who have these bundle branch blocks or paced rhythms on their EKG, we're going to use Sgarbossa criteria in order to call a STEMI in the field. So the first thing that's always talked about is appropriate discordance, which can be very, very confusing to think about. But basically it boils down to this. In a normal left bundle branch block, if the QRS complex is going down, you should see ST elevation, and that's normal. If the QRS complex is going up, you should see ST depression. That is also normal. So what does that look like? So looking at this segment, right, we have our P here. Here's our QRS segment here. This is going up in a left bundle branch block with that widened QRS, and it's going up. We should have ST depression. That is appropriate discordance. It's discordant with the QRS complex in that this is going up, this is down. You have depression, right, which you appropriately recognize, but that is normal in a left bundle branch block or a paced rhythm. Same for the opposite, right? P, QRS here. This QRS complex is negative, it's down. We should have ST elevation with that, right? And you'd recognize that. You'd say this is elevated compared to here, right? So this is ST elevation, but that's normal in a left bundle branch block. But this widened QRS that is going down, we should see ST elevation. That is appropriate discordance. You should not consider this a STEMI, right? There is ST elevation, but it's normal. So then the question becomes, we know these two things. What happens when we have a left bundle or a paced rhythm, but the patient is having a STEMI? How do we identify that? So one thing you can look at is concordant ST elevation in a left bundle or a paced rhythm. That is a STEMI. You can also have concordant depression in V1 through V3. That is going to be a STEMI equivalent. and then inappropriate discordance, when the elevation or depression that we just talked about is greater than 25%. So there's too much discordance. That is a STEMI equivalent. So let's just break this down to make this make sense. So starting with concordant ST elevation. This is a little bit tough to see, but if you look closely here, right, we have in lead 2 a widened QRS. This is our left bundle morphology. That QRS complex is positive, right? It's going up. Our ST segment is also up. There is concordant elevation. This looks like our normal STEMIs, right? We can see that here in lead 2, in lead 3, and in AVF. You have a positive QRS complex, and that ST segment is elevated, right? That is concordant ST elevation. If this patient is having chest pain, your context is right, that's a STEMI. Let's look at ST depression, right? Concordant ST depression, especially in V1 through V3. In a left bundle branch block or a paced rhythm, V1 through V3, you should have negative QRS complexes. Within those complexes, if they're negative and you see ST depression with that, that is a STEMI equivalent. And very often it's going to be representative of a posterior STEMI. So this is concordant ST depression in V2, concordant ST depression in V3. This should get activated in the right patient context. And then lastly, inappropriate discordance. So we just talked about normally in a left bundle block or a paced rhythm, a positive QRS complex should have some ST depression with it. A negative QRS complex should have some positive ST elevation with it. It can be inappropriate though, and what that means is that your discordance is too much. It's greater than 25% of the QRS complex. So if this QRS complex here is 10 millimeters and this ST depression is 4 millimeters, that's greater than 25%. That is equivalent to inappropriate discordance and could be considered representative of a STEMI in the right context. Same here, right? Our negative QRS complex is 10 millimeters. Our ST elevation is 3.2 millimeters. It should be 2.5 or below. Based on modified Sgarbossa criteria, that is greater than 25%. It's a STEMI equivalent. This is straight out of the STEMI protocol in your protocol, so you can review this there as well. This is very, very confusing, and I want to make sure that we all identify that. There are multiple resources online. Feel free to chat with one of us at any time and we can kind of go over it. But this confuses ED physicians as well as EMTs and medics throughout the world. So this is a difficult thing that even cardiologists disagree about sometimes. But the key takeaway here, right, is that if you see something that looks funky and it meets that concordant ST elevation or concordant ST depression, it's inappropriately discordant and it meets that Sgarbossa criteria, and the patient is screaming in chest pain and the story just kind of makes sense, you can activate that and you should. And our cardiologist should agree with that. So let's take a look at some examples that exist from actually our patients. These are our recent EKGs that were transmitted to the ED. And so here's one example. Take a second to take a look at this EKG and see what you see. So just to break this down in general, right, we see that classic widened QRS complex, suggestive of likely a left bundle branch block. In this case, we're looking for that Sgarbossa criteria, right? Is there concordant elevation or depression, or is there inappropriate discordance? And here we look, and looking lead by lead, this all looks pretty good, right? We have a negative QRS complex here. There's some elevation here, but that's appropriate, right? Negative with appropriate elevation here, right? Nothing meeting criteria there. This looks pretty isoelectric here. There's some positive QRS complex here with a little bit of depression. We expect that. Same in V6 as well. We see that over here in the inferior leads, right? You have a positive QRS with some ST depression, positive QRS with some negative ST depression. So this is all looking like a pretty standard left bundle branch block. This would not be considered to be a STEMI. Take a look at this one. Just for context here, this was in an older patient, and the machine read STEMI. So let's break it down. Again, we have that widened QRS complex that suggests that this is likely a left bundle branch block. And we see some morphology here that could be concerning if we don't break it down using what we know. So let's start. I like to start usually in the anterior lead. So we have this widened QRS and we have ST elevation. But if we look at this, right, this is a negative QRS deflection with some appropriate ST elevation here, right? So this point is not more than 25% of this negative QRS complex. That does not meet Sgarbossa criteria. Over here we have our positive QRS complex, and we have some ST depression. But again, this depression compared to here is not more than 25% of that QRS complex. It does not meet Sgarbossa criteria to be considered a STEMI. Same thing out here in the inferior leads, right? When you look at this and say, wow, that's some ST elevation here in lead 3, that's pretty concerning. But we have this big negative QRS complex here, so that's appropriate ST elevation, right? That's appropriate discordance. That's what we expect in a left bundle branch block. So this machine read STEMI, and this was transmitted as a STEMI, but this patient is not having a STEMI. This is a pretty typical left bundle branch morphology that we see relatively frequently. So this is an example of just because the machine says STEMI does not mean that this patient is having a STEMI. So to finish up, back to our key takeaways. Again, we'd rather overcall STEMIs than miss them. If you're ever not sure about something, feel free to give us a call. We'd rather you err on the side of calling a STEMI in the field than not calling it. But at the same time, we should be diligent and make sure we understand things like left bundle branch blocks and benign early repolarization and know that context does matter, right? You should look at what your patient looks like, their age, their risk factors, their symptoms, and see if it all fits to make a STEMI make sense. Bundle branch blocks, like I said, make everything more complicated, but hopefully we broke that down a little bit today and made it a little bit easier to digest so you feel more confident calling that in the field. And with that, again, we call STEMIs. The machine doesn't. Just because the machine reads STEMI does not mean that you have to call a STEMI in the field. Use your judgment at the end of the day. That's what you're trained for in order to make that call. So hopefully this helps. Pleasure talking to you today, and thanks for all that you do.